Thanks everyone for joining. On the call today from the STS, we have Emily Conrad, Paul Meehan, Banu Yagci, Addie Dolan, and Melinda Offer. Welcome to STS Database Help Desk Support. I am going to turn everything over to Paul and Banu so that they can share their program with us today.
Awesome. Thank you, Nancy. Let me just share my screen. Can everyone see my screen?
We see it.
Awesome. Okay. Hi, everyone, and thank you for joining us today. My name is Banu Yagci. Along with my colleague and co-presenter, Paul Meehan, we'll be covering several important topics today. First, we'll walk you through the new MPI validation functionality, what it is, what to do when you encounter error messages, and how to add context to your PID to help eliminate these errors. We'll also share best practices for utilizing the STS database helpdesk support effectively. And lastly, we'll go over some of the most common questions we receive at the help desk to help streamline and expedite responses to your inquiries. So we'll look forward to helping you get the most out of this session. So I'm pretty sure many of you already know by now, back in May 2024, a new functionality was introduced on the database platform called the NPI validation functionality. This feature specifically impacts participants who use third-party software vendors. And the main goal of this feature is to ensure that only cases involving surgeons or anesthesiologists listed on your contact list are accepted into the database. So here's how it works. If you upload a file that includes cases for a surgeon who is not on your contact list, the records will trigger a critical error, and those cases will not be accepted into the data warehouse. And additionally, any records that have an incorrect NPI number will also trigger this error, resulting in the rejection of the cases. So for example, if the NPI number for a surgeon in your vendor software doesn't match the one we have in our system, those cases will be rejected. The cases will only be accepted once the NPI number is corrected and the file is re-uploaded. So to avoid this issue, it's really important to ensure that all your surgeons and anesthesiologists, including locum surgeons, are added to your respective PIDs before uploading any cases involving them. So since we mentioned locum surgeons, I wanted to clarify a common question we often receive regarding the addition of locum surgeons to our database. Locum surgeons are treated the same way as any other surgeon in our system. This means they must be added to your site before you can upload any case forms for them. Even if they have only performed 2 surgeries within 2 years or 4 years, or you have a different internal system within your hospital or clinic for them, which is definitely understandable that you might have a separate system for them, we handle them the same way here at the database. So for each locum surgeon you have case forms for, you'll have to submit a participant contact form along with a signed and completed Schedule A or Schedule B form. Schedule A for surgeons and Schedule B for anesthesiologists. So what happens if a surgeon isn't added to your PID and you've uploaded cases for them to the platform? Well, as you can see here on the screen, you'll receive a critical error message just like the one shown here. This is an example of how the critical error will appear in your DQR, data quality reports. After your upload, if you see this critical error message, you can just simply click on the red section of the pie chart to access more details. And once you click that, in the section below the graph, you'll find the list of critical errors. And if you see a message that says anesthesiologist or surgeon invalid NPI error, it means that the NPI for those surgeons or anesthesiologists hasn't been properly linked to your PID. And to resolve this and successfully upload their records, you'll need to add those surgeons and or anesthesiologists to your PID. So here is the error messages that might come up when you're uploading where you don't have the right MPI number for a surgeon or don't even have the surgeon edit to your PID. So if you see a message that says record XYZ is referencing an invalid surgeon anesthesiologist MPI, it means that record was skipped during the upload. So any other records will be uploaded, but those records that don't have the matching NPI, they're going to be skipped during this upload. And here's what you need to do. First, check your contact list report on the IQVIA platform. Compare the surgeons and anesthesiologists in your upload data with those listed in your contact list reports. And, after you check the contact report, if you find that any surgeons or anesthesiologists are not on your contact list, you'll need to submit a participant contact form along with a signed Schedule A or Schedule B form to have them added to your PID. If all the surgeons and anesthesiologists in your data are listed on your contact list report, then the next step is to compare the NPI numbers in your data with the national registry. So once you do the comparison, and if you notice any discrepancies, please update your data with the correct MPI values and then re-upload the cases. We'll get into more details on these steps in my upcoming slides where I'll walk you through the process in depth. So since we mentioned the contact list report, I just would like to clarify one thing first. Please note that not everyone has access to the contact list report. Only primary and backup contacts can view and access this report through the database platform. And if you're a primary or backup contact, once you log in onto the platform, you can navigate to the operational report section on the left-hand side here. And then at the bottom of the platform, navigate to the, once you navigate to the operational report section, at the bottom of the screen, you'll find and be able to access your contact list report. Again, only primary and backup contacts have access to this report. So once you're in the contact list report, you'll see a list of names along with their corresponding roles. And this will allow you to easily identify the individuals who are on your contact list and their designated roles. Well, for the purposes of our training here, I've used a test site, so I don't have any contact list names, but you should be able to see all of your contacts, including your surgeons and anesthesiologists who are active along with their designated roles within this contact list. And if you review and don't see them there, please contact us so we can investigate and let you know what needs to be done. Since we mentioned the MPI registry, I just wanted to talk about this a little bit. For those of you who are new to the database and don't know what it actually means, the NPPES, NPI registry, is the national website where you can perform NPI queries to confirm the accuracy of a surgeon's or anesthesiologist's NPI number, or any other doctors for that matter. You can enter the surgeon's NPI number or their first and last name to verify that the NPI matches the surgeon's name in your records, or vice versa. It's really as easy as it sounds. You just log in, not even log in, just click on the hyperlink here. It'll take you to the site. And the next thing you do is either you put in the NPI number or the provider's first and last name, and voila, it's there. So for every participant contact form we receive with a surgeon's or anesthesiologist's NPI, we use this website to ensure the NPI matches the surgeon's name. It's a great tool, and we encourage everyone to use it to confirm NPI accuracy. So for those of you who are new and never done this before, I will just start by reviewing how you can add contacts to your contact list report. And if you need to add a new surgeon to your PID, deactivate a surgeon or an anesthesiologist, or make any other contact-related changes, the participant contact form is the right platform to initiate these requests. In short, it's called PCF. It's an online form you can fill out and submit. It allows STS to make the changes you request, and it's the fastest and easiest way to handle these updates. There are several ways to access the PCF form. The first one is you can visit the STS website, type participant contact form into the search bar and hit search to locate the form, and it'll come up right up. Alternatively, you can go to sts.org under research and data, and I'm sure you're very familiar with the data manager section there. Right under the data manager section, when you scroll down, you can click on the participant contact form under essential forms and resources. Again, I'm pretty sure this is a section you use very often. And it's right there along with the Schedule A, Schedule B forms, and any other documentation and resources that you might need. The form itself is a simple one-page document, as you can see on the right-hand side here, where you'll provide details such as the full name, MPI number, email address, etc. of the contact you're adding to your PID. And once the form is filled out, you can simply click submit and you're done. You can also submit multiple requests within one form. However, please note that a separate form must be submitted for each PID. So if you're adding multiple people under one PID, you can do so on a single PCF. But if you're adding one person to multiple sites, you'll need to submit a separate PCF for each PID. So we often receive questions about which database participant role to assign to a new contact when adding them to your PID. And to help with this, we actually have a document. It's, again, under Essential Forms and Resources in the Data Manager section. It's called the Participant Roles and Descriptions document. I have just provided a quick screenshot of it on the right-hand side. You can review this document for a detailed explanation of each role before submitting the participant contact form, so you can decide on the appropriate level of access for the participant. Mostly we're asked that, our participants would like to add a new data manager, and they want to give that person a read-only access. We wouldn't like to recommend or suggest anything. So it will be great if you can review this document and decide accordingly, because it just provides you all the information that you need. If you would like to give someone a read-only access, you can just look at the level of access here and assign the platform roles accordingly. Here's another question that we receive very often. Adding a surgeon or an anesthesiologist without a Schedule A form, because the surgeon or anesthesiologist cannot be reached. First of all, we do accept electronic signatures, so you can reach out to your surgeon or anesthesiologist via email and obtain their e-signature. For that matter, it doesn't have to be a physical signature. But please note that we cannot add a surgeon or anesthesiologist to your PID unless we have assigned and completed Schedule A or Schedule B form for that individual. This form actually grants us permission to work with the surgeons or anesthesiologists' data, which is why we cannot proceed with adding them to your PID without it. And additionally, contractually, you're required to submit a Schedule A or a Schedule B form when adding these roles to your PID. So this is a critical step that we cannot bypass. So please ensure that the Schedule A or Schedule B form is attached to your PCF if you're adding a surgeon or an anesthesiologist to your site. So as shown in the screenshot on the right, when filling out the PCF, you just simply answer yes to the question, are you submitting a Schedule A, B form, and then follow the prompts to attach the Schedule A, B form before submitting the form, and you're done. It literally takes less than 2 minutes of your time. And then, voila, you're done. And, on this slide, you can see the Schedule A and Schedule B forms. As I mentioned before, these forms can also be used for multiple surgeons and anesthesiologists as well, as long as they're under one PID. You just provide the PID number here, the name, signature, their address, and NPI. And again, you can add multiple surgeons and multiple anesthesiologists to these forms and attach it to your PCF and send it. And again, these forms can actually be found under the essential forms and resources. So this is an important point to note that only primary and backup contacts should be submitting the participant contact form. And if we receive a form from anyone else, we'll need to involve the primary or backup contact to get their approval before processing the form, which can, as you can guess, delay the process. So to avoid delays, we strongly encourage all of you to have your primary or backup contacts submit the online forms directly, please. I'll go over a couple of important points before handing it over to Paul, who'll be covering exciting topics. So as a reminder, if the PCF form is submitted by anyone other than the primary or backup contact, we will need to obtain approval from the primary contact or any of the backup contacts if the primary contact is not available for some reason. So this additional step will inevitably delay the process. So to avoid this, we strongly encourage primary and backup contacts to submit the form directly. There is a processing time for PCFs, and once we receive complete forms, like the form is complete and Schedule A or Schedule B is attached with a signature and filled out, they are all processed within 5 to 7 business days. We do make every effort to accommodate urgent requests, but please know that during high activity periods, such as near harvest close times, we might not be able to prioritize them. So to ensure timely processing, we recommend submitting your forms at least like 10 days prior to harvest close. So this allows time to address any surge in MPI error messages before the deadline. And for all PCF submissions, please avoid sending them via email to STSHD or other email addresses, as again, this will only delay the process. To ensure timely processing, all contact list additions must be submitted through the PCF form. Sometimes we do receive the PCF and then an email to the help desk, with a Schedule A asking us, to provide it to our colleagues or, to forward it to the correct department. Unfortunately, we can't. They need to be attached to the PCF and it's processed, and, there's a whole process that is done on our end. So it definitely needs to be attached to the PCF form. So please refrain from sending them separately. And, you can just resend your PCF along with the Schedule A or Schedule B form. And lastly, one more time, we've received numerous questions related to this, so I'd like to repeat this important information that, I find it is important to clarify that locum surgeons are treated the same as surgeons in our process, regardless of whether they perform 1 surgery or 100. So they must be added to your contact list if their cases will be uploaded. So this is everything I have for now, and I'll be now handing it over to Paul. Please submit any questions you have in the Q&A box, and I have been following that you have been doing that. So we will address them after our presentation. Thank you.
All right. Thank you, Banu. Actually, it looks like somebody has their hand raised. Do you want to go ahead and answer those questions before we get too far off topic, and then we'll switch to my stuff?
Sure, I can't see whose hand is raised.
Okay, so I'm sorry, I'm going to butcher your name, but it looks like Inga Dalsasaurus. You have your hand raised, but you're on mute. So if you unmute. Yes. Can you hear us okay? Okay, she took her hand down. So if you want to add the question into the Q&A, we could do it that way. And Banu, do you want to cover the Q&A questions first, or should I go ahead and do mine?
Yeah, you can go ahead and do your presentation. We can cover them at the end of
Okay.
presentation.
All right, do it that way then.
Sure.
All right, I'll share my screen then. Okay, can you see my screen?
Yep.
Okay. All right. Well, thank you everybody for coming. So I'm going to cover some of the parts of help desk and how to get help. And then I'm going to get into some of the other miscellaneous things that we find, there were some of the questions that we get through help desk to try to answer some common questions and stuff like that. And a lot of this stuff you may have heard in the past. And Melinda did a great presentation on doing the data submissions and covered a lot of the details here. I'm going to try to focus on more specific and common questions. So I'll start with going through the help desk. So for the most part, there's three main email addresses that you could use for getting help. And the main one, the one that Banu and I and Sydney manage, is the STSDB_helpdesk@sts.org. And we can't emphasize this one enough. That should be your go-to help desk. If you have a question and you're not sure who to send it to, this is who you send it to. And unless I'll explain the other two in a minute. But this is where you're gonna, if you're having trouble getting logged in, if you have a question about submitting your data or the reports, you have a question about your vendors, the red cap forms, it's just for the most part, most of the things that you're doing on a day-to-day basis should come to this help desk. Now we have two other ones, this STSDB@sts.org. That one is more for official business. So that is if your question is about contracts, if you're signing up for the anesthesia module, and anything dealing with money, billing, your invoices, whatever, all of that should go to this, the STSDB help desk. We also have the STSDB FAQ help desk, and this one is the one for clinical questions. So how do you code something? The definition, are interpreting the definition of the field? You have a question about the training manual or whatever, that should go to FAQ. Basically, if you can start your question with, well, I've got a patient that whatever, that should go to FAQ. That's a good question for FAQ. And there's actually two ways to get the questions to FAQ. You can go ahead and email it directly to this address that's up here on the right. Or you could use this link at the bottom that has has a web form where you could submit your question. That way is probably the more recommended way, is using the website, because that will prompt you for the information that you really need to make sure you include in your question. And I'll get into more details about that. So there are these other two help desks that you can send messages to, but they're very specific topics. If you're not sure, send it to the one that we started with, this one, the STSDB_help desk. All right. So regardless of which help desk you're going to, it's always best to have very effective communication. Keep it clear and concise and to the point. It makes it a whole lot easier for us to understand what your question is, make sure we're answering the right question, and get it to you in a timely manner and stuff. And making sure you have all the important information, like your participant ID. I don't know, a lot of times we can't just check on your email address because you might be associated with more than one participant. And then when I'm trying to repeat the problem that you're having, looking at the report that you're talking about, and I don't know which participant you're talking about. So, I have to do it 3 or 4 times to find where you're seeing the issue. Also, some things that kind of seem obvious, but tell us which report you're talking about. There's lots of reports out there, and it can take us a long time just to figure out which report you're talking about. And then the details, what time frame you had. Give me the step-by-step process that you use to get to the point where you're seeing the issue. I start in the report section. I pull up this report. I set this time frame, this filter for types of procedures, drill down to such and such, and then this is what I see, and this is what I expected to see. You know, getting down to details like that really helps a lot. And then pictures are worth 1,000 words. Send us screenshots. We love screenshots. And for those of you who don't know, if you're using Windows, using this window key, hit window, shift, and S at the same time, and it'll put you into this mode where you can capture the screen. I can even do it right now. And I think you'll be able to see it, but I'm hitting whoops, sorry. I'm going to hit Windows, Shift, and S at the same time. And you see that my screen goes a little gray, and I get this little highlighter here. And all you have to do is just highlight the section that you want and let go. And now it's on your clipboard. And so you can go into your email message and hit paste, and it'll paste that uh, little clip that you took right into your email message. And that tells us worlds of information, lots of stuff that you wouldn't even think that would be helpful. And it like answers the question right there, and really directs us to what problem you're seeing. So we really emphasize sending us screenshots. We love them. A couple things not to do in sending messages to help desk. Don't CC anybody. Don't send it to multiple help desks. Don't send it to individuals. I know that you have become, familiar with some people that have helped you in the past. Don't send the email to them. Don't send it directly to them. For one thing, we keep track of all the messages that come into us so that we can see what areas are people having trouble with. You know, this is how we determine, is this problem an individual's problem, or is there a problem with the report? And we don't, if the messages you're sending are going to individuals, then we don't see it in help desk, and we don't know that it's a systematic problem that we need to jump on and get our developers to help with and stuff. Plus, it's also not their job. They've got other things to do, and help desk is designated to help you get your answers quickly. But probably the main thing is the reason why you're going to get faster responses is because there's multiple people monitoring the help desk. And so if somebody's off on vacation and you've sent the message directly to them, you're not going to get an answer back for at least a week. So if you send it to help desk, somebody is always monitoring help desk. And if we don't know the answers ourselves, we can get it to the people that can help answer your question. So do make sure you just send it to the help desk. Don't send it to multiple. And another thing people like to do is send it to everybody and multiple help desks or multiple people, thinking they're going to get a faster answer. That actually slows things down, because half of these systems, when you send an email to them, it creates a ticket for them. And then you've sent it to multiple desks. And so multiple tickets have been entered. And now everybody has all these things that, we don't know who's already answered it. We have more work to do, more tickets to close out. It confuses the conversation. It really messes things up. It really slows things down if you send it to too many people. So just pick the help desk, send it to there. We'll take care of it from there. And lastly, big thing, don't send emails to IQVIA. If you see in the subject, in the address that it's IQVIA, don't send it there. One thing I want to point out is that the platform that IQVIA is using so that we can provide you with the site IRP for getting in and putting in your data, submitting your files, seeing your reports, all that sort of stuff. That's a giant platform that they've created that they use on multiple contracts. And so there's parts of it in there that we don't have control over and we can't change because it would affect other contracts. So there's lots of things that we would love to change, but that we're just not able to. And one of them is the little button at the bottom that says, hey, if you have a question, click here and send a message to this help desk. Don't use that one. Okay, we can't get them to hide it because they need it for other purposes, but the help desk that goes to, they have no idea what you're talking about. They don't even know what STS is. So I you know, don't send it to that one. It'll take too long. And a lot of times, depending upon which one you're clicking on, those help desks aren't even manned. So you're not going to get a response at all from that system. Another thing that will happen is you send a message to that help desk. They say, oh, this isn't for us, and they close out the ticket. Now you get a message that says, hey, your ticket has been closed and completed. Okay. And to you, you haven't heard from anybody yet. So it just adds confusion. So again, just best, you know, unless you were responding to a message that they sent to you specifically, don't reply, don't send a message, don't originate a message to IQVIA. Yeah, so I think I beat that one enough. Another thing, please don't send us encrypted messages. For security reasons, we don't like to open encrypted messages unless we know that somebody's sending us the encrypted message. I think you all know how, you know, viruses work. They trick you into clicking on this link in the message, and it kicks off some software that's behind it, and that's how you get the viruses. Well, you can send a message to say somebody saying, hey, I got this encrypted message for you. Click here to open the message. That kicks off the virus. So for that purpose, unless we know that you're sending us an encrypted message, we're not going to open them. So please don't send them encrypted to us. If you have to send us PHI, then go ahead and encrypt it. But it's best to send us a message first and say, hey, I've got a question and I have to give you this PHI, so I'm going to encrypt it. Now we know to expect the message from you, and we'll feel better about going ahead and opening it. So.
Can I
All
add
right.
one? Can I add one thing else about
Sure.
encrypted?
Please.
So in the FAQ mailbox, if you send me an encrypted message, normally that's, you know, it's like Paul said, I need to know you're sending me that. But the other thing that happens is if this message needs to be sent to the surgeons, or the information you sent me needs to go to the surgeons, those messages expire. So sometimes it's really difficult for me to have that information when I need to give it to the surgeons if you send it to me in an encrypted message. So keep that in mind too. It does make things difficult. And sometimes I even have to reach out to you and say, hey, you know, that message expired. I need you to resend stuff to me so I can get it to the surgeons. So just FYI. Thanks, Paul.
Sure.
Yep. And can I make a comment on that also?
Sure.
Thank you. For exceptional risk, I send you an encrypted email, and we ask that you reply back to the encrypted email with your records for that reason. So,
Yeah, I think the real take-home message is, if you can avoid it, don't put PHI in your email message, and then encryption isn't needed. Okay, so try to make sure you're not putting anything with patient identifiers in there. But there are times when you do have to have patient identifiers in there. You know, like, you know, Nancy says, you know, we're asking for your list of patients for whatever reason. You have to identify the patient there. So, you know, it's okay to encrypt it in those cases, but just make sure you're not sending PHI unless you absolutely have to. That seem to cover everybody?
yep.
Okay,
Thanks, Paul.
sure. Okay, so again, you know, don't sending an effective email. You know, we tend to get messages, and you know, we love our surgeons, but a lot of times, you know, we get these really short messages says, you know, report's not working. Not saying which report, or who they are, or what participant they are. You know, or we get the question, why does this report say I have only 125 patients? You know, well, why does that look bad? First, who are you? What's your participant ID? Which report are you looking at? You know, give me the details. What are you seeing, and what were you expecting to see, to help me know what the difference should be? And then, you know, of course, the screenshots. All right. And then response time. So Our response time is usually within 48 hours. Actually, it's, taking the average is probably closer to like 6 hours. And we try to make sure that all of our questions that can be answered are answered by the end of our workday. We are working, well, it's, 9 to 5, central, it's actually 8 to 5 central time. Um, and we try to make sure that all of our messages are being dealt with by the end of the day. So you're usually going to get a message, within just a couple of hours, but sometimes it takes a little bit more digging, or we have to hand it off to multiple people to get all the information pulled together and figure out what's going on. Or if it really does look like it's a problem, we have to get the developers involved and blah, blah, blah. So it can take a little bit longer. But, in any case, please be patient and give us a little bit of time to work with it. Sending us more messages isn't helping the issue. We're getting back to you as quickly as we can. And do give us at least 48 hours to get an answer to you. All right. So I'm going to switch gears here. That's enough for help desk. Now getting into uploading files. So of course, this is only going to pertain to the participants who are using vendor software, not the direct data entry people. And so when you upload your file and you get into your data quality report, there's 3 main types of errors, starting with the critical errors. Critical errors are the ones where the record is being rejected. There's a problem in there. It could be that the entire file is being rejected, but at a minimum, 1 or more records are being rejected. And an example of this is that, you supplied an invalid value. We can't deal with values that are, if you send me an age of yellow, I can't do anything with that. I can't even stick that into the field. So I have to reject the entire record for that. The errors are ones where the record is being accepted, but certain values are either ignored or potentially even set to missing. An example of that is the message where the OR entry date cannot be greater than the skin incision start date. Right? You're not going to start cutting into the patient before he actually gets into the operating room. We don't know which one's right and which one's wrong. So we could potentially just ignore both of them or set both of them to missing. But something's definitely wrong. If that's correct, I think you have a bigger problem than just bad data. I think you need to talk to your doctors about starting the incision too soon. So that's an example of the errors, and that could be why you're seeing data reported in the missing variable report. It's because you sent bad data and we set it to missing. So that's another area to keep an eye on. And then there's the warnings. Warnings are the records and the values are being accepted, but something still looks a little bit odd and you might want to check into it. An example is if the A1C level is greater than 6.5, but the diabetes is not marked yes. So meaning the diabetes is either missing or it's marked no. That's pretty inconsistent. That's a pretty clear definition. The patient's diabetic. So you might want to check that. Again, we don't know which one's right and which one's wrong, but something seems to be odd there. So you want to check that out. So those are the 3 types of errors that you'll get in your data quality report. And when you get into it, you click on the level of error messages, either the warnings or the critical errors, and you get your list of patient records here and the details about that. And I'm going to reference back to this. I realize that some of this stuff can be confusing, and so that's one of the things that I want to cover here. I'm going to start with the messages that you get where it says that the record blah 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 has not changed, no updates made. Okay, you're going to see this warning message when you submit a data file and it contains the records that we've already gotten from a previous submission. So you're sending these records in a second or third time. we already have that record in the database, and we're also finding it in the data file. What this message is telling you is that the values that are in the file match exactly with the values that are in the database already. So, and I don't want to bore you too much with the technical details, but they start with the record ID. They find your record ID in the file, they find it in the database, and they compare every value on that record. And if there's even just the slightest change anywhere on any of those values, then it's considered an update, and we update the entire record. Okay, but if they're identical, then we don't need to do anything with the file or with the record, because there's no change to be done in the database. What you're sending us is exactly what we already have. All right. So if you think about it, we've got 1,000 sites sending us data files with thousands of records. It's going to save processing time if we don't do anything with the records where there's no updates to be made. We already have the data in the database, and no changes are needed. Okay, so that's where we're saying no updates are being made. That's what that situation is. And actually, if we go back to this screen where you had that message, this part over here, where the source patient ID, this confuses everybody. And I fully understand why this confuses everybody. And this is one of the areas where I wish we can make a faster change, but we're working on it. But people panic when they see this, and they think this is saying that your patient ID doesn't exist in your data. Okay. Patient ID does not identify your record, because you could have more than one record for that patient. So record ID is what we look at. So the process of trying to see if this record already exists involves open up the data file, get the record ID, and look for that record ID in the database. If those two records are identical, you don't do anything, including pulling out the data like patient ID. So we haven't touched patient ID yet. So patient ID is not available to the system. And that's why it shows up here as saying no patient ID available. Okay. So you could just, you can kind of ignore this part of that message when you see it, that it says that, this record is not changed, no updates made. You could ignore this part that says that patient ID is not available. It's not available to the system, but it's there. If patient ID was not on your data record, that's a critical error. You'd be getting a whole different error problem there. And it would be pretty obvious that that's what the issue is. So I know that one confuses a lot of people, and we're really trying hard to get that one changed, but that's one of the big ones that we have to go through a big system to get that one updated and stuff. So, so be patient with us on that one. All right, another uploader message is this one that's has a whole lot of gobbledygook here. If you notice, you'll see your participant ID is in here and a record ID is in here, but you got all this other garbage in there. We're trying to get that cleaned up too. The important part is saying that it's a duplicate of an existing record. The existing record has been updated. So this is an example of where we found the record ID. We looked it up in the database. We found that we already had this record. We compared the two records, and there was a change. They're not exactly the same. So in those cases, we take all the data that you're uploading, and we replace what we have with that data. So we've updated that record with all of your changes. That's basically all that's saying. So that one's pretty straightforward. Okay, then we're getting down into the warnings. A very frequent warning that you'll get is when your value is outside of the usual range. And you could end up getting quite a few of them. And we know from talking with people that the habit could be to just kind of ignore these and really focus on the critical errors and the other errors. And where it is more important that you fix your critical errors and your errors, these warnings are very important too. And especially for the usual range. Usual range is defined in a way where if your value is outside of that usual range, it's feasible, it's clinically possible, but it's probably more likely that you've mistyped it. You've put in the wrong value into the wrong field, or you just fat fingered it and or transposed two of the numbers or something like that. And like this example, like you know, the usual range for age is 18 to 100, whereas the valid value or the valid range is 0 to 110. You know, now could you be doing an operation on a 17-year-old patient? Yes, you know, not likely to be doing bypass on a 17-year-old, but you could. So we want to allow that value, but it's more likely that you just transpose those two and it's actually a 71-year-old patient, not 17. Or, you know, you've, you know, whatever, you've done some sort of typo or something getting the data in. So even though this is just a warning and it's just saying it's even saying it's a valid value, it's just outside the usual range. You don't want to just blow it off. Do look at it closely and make sure that, you know, what you've entered is correct. It'll help us make sure that we're analyzing your data correct. You want everything as right as possible. And we do know that some people say, well, you know, we regularly have values that are correct, but they're outside of the usual range. If that's happening for specific fields, send it to Helpdesk, let us know, and we will take that into account when we're doing the next spec upgrade. You know, we're working with the surgeons when we set these limits, and we do our best to try to make sure that it's not triggering too many false positives. But, you know, we get it wrong sometimes. So if it happens a lot, send it to Helpdesk and we'll add it to the list of things to consider when we're doing the next spec upgrade. All right. The other question that we get a whole lot on Helpdesk is missing variable report is saying that this field is missing, but I see it in my vendor software. You know, why is this being reported as missing? A lot of times when that happens, it's, you know, I just uploaded the file and then opened up my missing variable report and it's still saying that it's missing. Well, you have to kind of give the system a chance to chew on your data. I mean, that you may get the message that it's done uploading the file, but it still has to get through a lot of other systems, and then those reports need to be regenerated and things like that. And so it may, you know, to you, you've got the correct data in there. It's just not showing up in the report. So give it a little bit of time before you do that. Especially when we're getting close to the end of a harvest, because we've got a bunch of people hammering on the system and it just slows everything down, and it can take a while before that data gets processed. You know, if you've submitted the file and the next day the report's still saying it's missing, then it's probably still missing. It's probably something else. It's not a timing issue. If that's the case, one of the other things you could do, you know, 99 times out of 100, when, you know, the files, when the report says this field's missing, it's missing. We didn't get it. So check things on your side before sending in a question. So another area that you can check is working with your vendor. You know, ask them if they can check the file that you're producing and seeing why this field's not being included in there. Because usually they'll be able to come up with an answer for that. And then the other problem that we find a lot of times is, you know, somebody sees that their value's missing, they go into their vendor software, they put the value in there, and then they look at the missing variable report and they say, well, it's still missing. It's like, well, you have to send it to us. If you've updated your data, you have to make sure that you've sent us that data. And a good way to check on that is if you get into your data quality report for any of the uploads that you've done. Down at the bottom, you know, normally you're looking at the data quality report here, but if you look at the critical summary tab, it'll open up this other report, and you put in a start date over here on the left and an end date, and click Run Report, and you'll get this list of all of the uploads that you have made between those two dates. It'll list the date that you uploaded the file, gives you the upload ID, and most importantly, it gives you the first date and the last date included in that file. And so if you know that the record that's being reported as having a missing value is, has a particular date, you can look in this list and see when was the last time you updated that time frame. Because it could be that, you uploaded the file, you got the report back saying it was missing. You went into your vendor software and updated it, but you never sent it to us again. So that would be a clue to you that you're not sending us your latest updated data. So that's another area that you can check. Okay, throwing a lot of data, a lot of information out here. So we're going to switch here to, I'm going to give a quick comparison of some differences of whether you're working with a vendor or whether you're doing direct data entry into the IQVIA platform. We usually abbreviate that DDE. So for vendor users, you're entering your data into the vendor software, you extract it into a file, submit that file to IQVIA, and then you look at your reports, your missing variable reports and things like that. If you see that something's wrong and you need to make an update, you go back, make the update in your vendor software, and then you have to re-extract that from your vendor software and submit another data file. So that's the usual process there. For direct data entry users, when you are entering your data in the IQVIA platform, as soon as you hit the save button, it's there. It's in the same spot that it's going to end up as if you had submitted a vendor file. It's going into the exact same database. So once you've switched to DDE, there's no longer a need for you to submit your data. Every time you hit save, you've submitted your data. It's already done. And then if there's any updates that need to be made, you make them directly in the IQVIA platform. You pull up your record, you make your changes, you hit save, you've submitted it again. It's already in the database. So regardless of how you're getting that data entered into the system, they both end up in the exact same place. All right. Now, whether you're working with a vendor or you're doing direct data entry, there's usually a checkbox in there somewhere saying that the record is complete. You've entered all the data that you can, and you think that you have everything in there and that it's correct. So you check it off as complete. That's important to do because for both the vendor and the direct data entry systems, there's certain data checks that they're not going to do until you say that it's complete. We understand that somebody's going to get in, you guys are going to get in and start entering your data, even while, the patient's just being admitted and, you haven't even had the procedure yet. And, or they just had the procedure, but they're still in the hospital. And you may not have all of the answers yet. You're still collecting that data. We want you to be able to enter as much data as you can and come back to it later to finish it off. So we don't want to bombard you with a bunch of error messages and prevent you from saving that record if you just don't have the data yet. So so those types of edit checks aren't going to fire until you check it off as complete. All right. So whether you're using a vendor or doing direct data entry, you want to make sure that you do check it off as complete so that those edit checks do fire and that you make sure that you're getting your data checked as accurately as possible. Now, whether the record is checked as complete or not is irrelevant as far as submitting the data. So your vendor software is going to send us all of the data, whether it's complete or not. And for direct data entry people, whether you've completed the record or not, come harvest time, those records are being picked up. We're getting all of your data. And the analysis is designed to look at your data and determine which ones have all of the data that they need to do the analysis. And if it doesn't have the data, it gets excluded from the analysis. So the complete button is very important for you to make sure that your data is correct and has been checked properly, but it's irrelevant as far as harvests and analysis is concerned. Right. Okay. And another warning for direct data entry users. And especially for people who have switched from using a vendor to doing direct data entry, make sure that you do not submit files. So once you switch to doing direct data entry, you may still see the button in there that says submit, to upload your files. Don't use it if you're doing direct data entry, because if you submit a file, you're going to overwrite all of those changes that you made manually. And there's no getting them back again. You have to go in and make them all again manually to get that data back again later. So you could really hose things up if you submit a file and you're a direct data entry user. So please don't do that. That's one of the things that we would like to have change, is have that button disappear if you're direct data entry, and we're working on that. So, for people who were using a vendor and submitted data that way and then switched to direct data entry, for those people, you can go back to your old records that were originally submitted from your vendor software and make your updates through the direct data entry platform. Because, I mean, essentially, you're currently a direct data entry user, so you can do all your edits directly in the system. And then if you're switching from direct data entry to using a vendor, you can get your current data that's in the IQVIA platform. You can get that out using the data download report, and that's explained in the library and everything. So I'm not going to get into too much detail about that, but know that that's available too. Okay. Excuse me while I grab some water here. All right. Next thing I want to talk about are the supplemental forms that we have. For ACSD, we only have 2 supplemental forms, one for the beta blocker study and one for the extra valve devices. The REDCap forms are located at these addresses, and I'm not going to get into the details of what goes into what, but I think most people are already familiar with that. The main thing to know is that you do not need a user ID or password to get into the REDCap forms. So if you try to get into the form and it's prompting you for a user ID, you're probably using the wrong link. You're going to the wrong site. So you should not need a user ID and password to get into there. Once you, if you get into the at the STS portal and you get down into the, get down to the data collection forms, or data collection information, additional resources, there's a link down here to navigation of REDCap forms. This explains how to create the record. When you save the record, you get a return code that you want to keep a track of so that you can get back into that record to make changes if you need to. And stuff like that. The whole workings of how you set up your REDCap forms, that's all explained in the document there. So I'd recommend that you check that out if you're working with these forms. If you do need to update a record that's in REDCap, how you do that depends on whether you have that return code or not. If you have the return code, you can get back into that record directly and make just whatever change you want in there and just save it again. And those updates will be saved in the database. If you don't have that return code, then there's no real way to get back into that individual record. But what you can do is create a new record. Now it means re-entering all of the data for that record, but just, you're going to give it the same record ID, of course, because it's still associated with the same record in your vendor software. When we do the analysis, if we find 2 records in the REDCap form that have the same record ID, we take the one that was entered last. So if you feel like you need to make an update to your form, you could go ahead and just re-enter it and know that the previous one will be just ignored. And if you have to do it 2 or 3 times, you go ahead and do it 2 or 3 times. We just always take the last one that has been entered. So that's how you make updates to the records. If you want to delete a record, now the only time you want to delete a record is if you realize that patient didn't qualify for like the beta blocker study or whatever. And so they shouldn't be in the database at all. In those cases, you want to have the record removed. Again, it depends on whether you have the return code or not. If you have the return code, you can get back into it, go to the record ID field and just add the word remove to the record ID. So for example, you'd change it from V990001 to V990001_remove. And if we see the word remove in the record ID, we know that you want that record deleted. You know, that'll take care of it for you. If you don't have the return code, then you can't make that edit. And actually, there's really no way for you to delete the record then. But if you go ahead and email us at Helpdesk, we can do that for you. So just supply that information to us and we can help you there. All right. Now, some of the vendors have, we've supplied the vendors with the information of these REDCap forms, all the field names and everything else. And some of the vendors were able to incorporate this into the vendor software. So you don't have to go to REDCap to enter this additional information. You can enter it directly into your vendor software. All right. If that's the case, if your vendor is supplying this for you, if you've already been entering data into REDCap, you can just switch and start recording it in your vendor software. You don't have to have the data in both places. Again, if we find the same record ID for your participant, we find 2 copies of that, we just take whichever one was entered last. So there's no need for you to enter it into both. If you do have it in both, that's not a problem. It'll all get combined together and we'll take the last record for each record ID, and that's what will be sent to analysis. The other thing to be aware of is that if you're entering this data into your vendor software, your vendor's going to send that data to us. That's not part of the file that you submit to IQVIA. That data gets sent to us by your vendor separately, and we do it like once a harvest and stuff. So that's just how we get that data. But in the end, the data we get from the vendors and the data that's in the REDCap form get merged together into the same table, and so it all gets pushed together in the end. Last thing I want to say about this is just that not all vendors are able to incorporate these supplemental forms into their software for no fault of their own. This was an idea we came up with after the fact. So the way that we're collecting that data, as I said, the vendor sends the data to us. And just as an example, I know of at least one vendor where their security model does not allow them to do that because they don't have access to the participants' data. They have access to the software, but not the data. So they're not able to send us the data, so they can't participate this way. Absolutely understandable, no fault of their own. We threw this wrench at them, halfway through the processing and stuff. So don't blame your vendor if they don't have it. But you might want to check with your vendor to see if they do have it or not, if you're interested in participating in that. And that's all that I have. So thank you very much. Anybody has any questions? I think we can switch now. Let's see if I can pull up questions. It's so quiet on this end. I just feel like I've been talking to myself. So it's kind of creeping me out, actually.
Nancy, you want to start by reading the
Yeah.
questions, or do you want us to?
No, I can read the
Okay.
question.
Thank you.
Yeah, give you guys a break, right? been talking for a long time. All right, so the first question is from Elizabeth. Is there a reason why the contact list report does not include the role of billing contact and contract contact? This would be helpful if it could be added.
Well, I'll take this one, Nancy. They're not added to the they're not added to the contact list report because those roles should not have access to the IQVIA platform. We have a separate system where we enter them, and if you don't know who your current billing and contract contacts are, you can always email the help desk and we'll provide them for you. But we're not planning on adding them to the IQVIA platform or the contact list report anytime soon.
Thanks, Banu.
Sure.
Jacqueline is asking, what is the best way to handle locums that perform surgeries at more than one of our hospitals?
I think I could take this one, Nancy. This is Carol. Hi, everybody.
Thanks,
But I might
Carol.
need a little bit of clarity on it. Jacqueline, are you asking if they need to sign individual Schedule A's for each of the hospitals that they're participating at? Or are your hospitals all participating under one PID? Locums, if you could provide that additional information in the Q&A, I can probably provide you an answer. They are not all the same PID. So if they're performing procedures at your hospital as a locum tenens, and they should be signed on to individual Schedule A's for each of those hospitals, it's up to your site if they are collecting data on the locum tenens or not. Let me know if that helps, or if you'd like to send me an email, I can probably address it a little bit differently or better.
All right. Thanks, Carol. Elizabeth is asking, when did the signature type change from a physical signature to allowing an electronic signature? I just know that in the past I submitted an electronic signature and the form was not accepted, and I was told it had to be handwritten and resubmit the Schedule A form.
I'll take this one, Nancy. I'm not sure when the change was done, but since we started handling Schedule A forms and Schedule B forms and responding questions regarding those, about like 2.5 years ago, we have been accepting electronic signatures as long as they are legit electronic signatures. And as you know, once it's electronically signed, there can be no changes made on it. And we do accept them, and you can definitely request that via email from your providers, even if they're not working for your PID anymore. Thank you.
Thanks, Banu.
Sure.
Kelly is asking, is it possible to set up a system where we can upload documents with the STS clinical question when submitting online, ensuring that no PHI is included?
I think that sounds like a good idea, but we'll have to look into that. That hasn't been discussed up to this point, but we can check into that.
Yeah, I think, well, I discussed this with our IT team a few years ago about adding some type of like a Dropbox. We have the ability to do that, but we're not comfortable doing that because other people outside of our team have access to that. So we prefer that you reach out to us with the question and then we reach out to you for the additional information.
Thanks, both of you,
Mm-hmm.
Paul and Carol.
You're welcome.
Laura is asking, in direct data entry with records entered directly to IQVIA, should the STS patient ID and the STS record ID be the same?
No. Patient ID and record ID follow the same sort of formatting. So they're all going to start with V. They're going to have a 2-digit code after it that tells me who your vendor is at the time the record was created. And then the rest is just an arbitrary number. They're two very separate values, and they can have anything at all, and there's no correlation between the two fields. The way
Yeah,
they
there's no,
usually get created, though, is, it's going to be like V99001 for your first patient. And then you create your first record for that patient. And so it gets record ID V9900001. And then you enter patient 2. So you get patient ID V99002. And the operation record for that gets V9900002. So it's the same. And you'll see that they'll be the same. But then eventually one of your patients is going to get another operation. And then that's going to throw things out of sync, because then you go back to V9900001 and you get record ID V99003. And that's, so now you're no longer in sync and stuff. So, basically I'm just trying to say it can be the same, but it's actually kind of weird that they're the same. They're completely different numbers and they have no correlation in between. They're just arbitrary numbers. And it's really, it's the order that you create them. So it's not even correlated to surgery date or admission date or anything like that. It's a random number.
And we talked about that on, I think that was data manager session 2. We talked all about that.
Mm-hmm.
All right, thank you.
Mm-hmm.
Beth has a comment about the ranges. The usual range is most often correct. There are very few that are more likely wrong. Some of the ranges have no, that question went away. Some of the ranges have no relation to actual sick patients. And then I saw someone else, Beth agrees with Beth.
I'd like to say something, Beth. We
Yes.
look at those ranges when we do the upgrade. So thank you for your comment. We're getting ready to work on an upgrade, and we will certainly take that into account. And if you have some specific examples, could you please send that to me or Nancy?
Thanks, Melinda. D is asking about the valve red cap form. Is this for any device that is not listed as an available device in the software? Also, how do you code for the device if it is not listed?
Yes, that is what it's for, is if it's not in the, so the idea is that when we did the spec upgrade last time, we came up with the list of valves and devices that were available at that time. And then new devices come along. So you might have devices that are not in the data specs. We can't update the data specs, and your vendors are not allowed to add anything to that list. And we don't have a code for every single new device that came along. So the idea behind the red cap form is to allow you to enter that data so that we know what new devices are being used frequently and need to be added to the list when we do the next spec upgrade, which we're in the process of doing. So it's a good idea to get your devices in there. If we find one that is, one person used this out of everybody, it may not make it into the spec upgrade. But if, a couple hundred people are using this valve, this device, then that's an indicator we need to make it one of the choices. And there is no code for it. That's the whole reason for having this, is that it's, we do have some, we are looking at what comes into the red cap form. And if we're seeing devices that are showing up frequently, we're making those available in the drop-down list. And actually, I don't know, do they even see the code for those? I don't know.
Paul, can I add just a few
Sure.
to your comments? So D, in the in our data collection form, if your valve is not on the selection set, then you would enter other approved FDA or other non-approved FDA valve, and then you would go to the red cap form and enter the valve that's probably most likely new because it wasn't on our selection set when we did the upgrade. We can only change that selection set with an upgrade. And, it's been a long time since we started version 4.2, so a lot of new devices have come out. So, but in our set, you would just put other FDA approved or non-approved and then go to the red cap.
And also, I would like to add, if the valve is not, or the valve device is not listed in the red cap, you would choose other. And it would be helpful if you could enter the model number, the manufacturer, and the name of the valve. It would help us be able to map that easier so that we can select the right devices for when we do the upgrade.
Yeah, I think let me emphasize that. So in the red cap form, if you don't see the device there, you choose other, and then it'll prompt you for, that'll open up the question to say, okay, here's a free text field, just put in whatever field, whatever device you're using that we don't know about. So that's where you want to put that information. Model number tells us all kinds of things. Please put in the model number. That really helps us know, because there's a million different spellings of everything and different abbreviations of everything and stuff like that. But the model number really tells us which device you're talking about. So please be sure to include that.
Paul and Melinda? Any update on when the beta blocker red cap will end? I do not have an update on that. Carol or
Yeah.
Paul?
I don't. I know last I heard there wasn't a plan for an end just yet. They're basically just keeping it open until we have enough data to be able to use for analysis to figure out what's going on. I don't know if Carol has more to add to that, but I think that's why it's continuing, is just to get as much data as we can.
Thanks, Paul.
Mm-hmm.
Excuse me. Jennifer is asking, could you please advise where we can find denominator definitions for all measures in the ACSD risk adjusted national report?
Report overview.
Report overview in the process and outcomes measures document. I believe it's still called the NQF document on the website. And then also it depends on which report you're looking at in the risk adjusted report. They're calculated a little differently from the composite and then the benchmark reports.
And we talked about this was that last week, right, Nancy? On the last data manager session, we talked about this at length.
Right. Jennifer, I can send you an email with a little more information. We had already been chatting about this. But it really depends on which report you're looking at as to which source you would go to for that information. Laura says the IQVIA created record and patient IDs are the same.
They can be. Like I said, they're arbitrary numbers. They have no correlation to the two. They might be the same. They might be different. It doesn't matter.
Thanks, Paul.
Mm-hmm.
And then Blair agrees about the ranges, particularly with high volume centers. Let's see. Rochelle, we have to enter a red cap valve form on every patient who has a valve that isn't present in the selection. We have a ton. It's a lot. I hear you, Rochelle. It can be a lot, especially if your center is using the newer valve implant devices. But we are working on it.
And the new spec upgrade is coming in the near future. So we will have an updated list in the vendor software soon.
Right. Thanks, Paul. Then she commented, all of their TAVR implants and about half of their aortic valve implants they're having to put into the red cap. And yes, a spec upgrade is coming. Dee said thank you. John has 2 questions. Is there an option in the future to pull data by individual provider? And number 2, is there a way to pull data for a longer period of time? We have one provider who wants his volumes for mitral valve repair and mitral valve replacement from 2010 to present.
If you're, okay, you're talking about by surgeon, right? The reports are not designed, that the reports are designed for participants, not surgeons, but we do have the surgeon composite reports. Those have, I believe it's the same time period as whatever the current report is. So if you want something that goes back to older data, I don't know if there's a way of getting that or not. I don't know how long those reports are maintained, that we would be able to send you an old report or something like that. But so as far as like being able to go back farther for the composite report, I'm not sure about that. There's a surgeon volume report that's available that gives the surgeon a breakdown of the number of operations that they've done for the different uh, types of procedures. That is basically, that goes across all participants. So that's generated by the surgeon's NPI number. So if one surgeon works for multiple participants, all of that's going to be joined together into the one report. And and that will go back. That's the entire database. So that's every record that we have back to the point of where we collected surgeon NPI, which is like 2007, I want to say. I'm not sure if that's right or not, but somewhere it goes way back. So that's available for the surgeon. That'll go back to everything we have for them. But those reports are only available to the surgeon. The administrators and data managers and stuff will not be able to download that report for the surgeon. They got to go get it themselves.
The other thing I would add on to that, Paul, is within if you're using a third-party vendor, there's usually a way to query the data within the vendor software by surgeon NPI. Hope that helps.
Okay.
Yep. Thank you both. Lori is asking, with the upgrade, is there a way to sort by device, model number, or name to make it easier to enter?
When we create the list for the vendors, they all start with the model number. So, and usually, if you go into the field where you're selecting your device and start typing the model number, that should come up. We've specifically designed it that way to make it easier that way. I don't think you want to have it sorted by name, because there's just too many weird combinations of names. Then it wouldn't help you find it. But again, model number is key. That's why we ask for that. And all of the device names, we have it start with the model number. So yeah, that's what you should be using.
Thanks, Paul. I put a link to the national report overview and also the NQF endorsed measures into the chat. That will give you some information on the denominators. Sean is asking, is it required that locum doctors be included, or is it up to the facility and the locum surgeon?
Yeah,
Should be included.
I can take this one. STS does not dictate that all of the surgeons have to sign on to a Schedule A at the hospital. It's up to the facility, their contract with the surgeons, and how that's handled. We do strongly encourage all data performed at your hospital by all surgeons, cardiac surgeons performing cases, to be submitted to the STS database, and every surgeon should fill out a Schedule A. But STS cannot, does not dictate that to the sites. It's between the sites and the surgeons and their contract. It's important if you have a surgeon who doesn't want to sign the Schedule A or doesn't want their cases included. I think it's important to understand why and educate them on risk adjustment, the importance of fully for the quality of your hospital, the quality improvement practices at your hospital, and to understand performance at your hospital, the importance on that. And if you have any questions, you can reach out to Jane or you can reach out to us at STS.
I mean, basically, if you're, the reports are trying to show what's happening at your site, not including all the records happening at your site.
Yeah.
We can't give you a good, clear picture. So, yeah, it's kind of silly not to.
Yeah, I think the hard thing is sometimes the locums come in and they are maybe just covering for an emergency and only, it could be that they're only covering emergent cases at the facility. Well, the lead surgeon is out. And we've heard some, we've had discussions about it, but in our contracts, it's, STS cannot force a surgeon to sign the Schedule A, but it could be in the contract that the locums has with the hospital for that purpose. So yeah, we absolutely want to provide the best reflection of your hospital's performance, but understand that there's situations where it has to be a discussion between the hospital administration and the surgeon.
All right, thanks. You're welcome, Jennifer and Michelle. And looks like there are no more questions, and we're right at time. So thank you so much, Banu and Paul, for sharing this very helpful information with us today.
No trouble.
Thank you.
Thank you very much.
Yep, and tomorrow is our monthly webinar. We'll be doing the data manager survey tomorrow. And then next Tuesday on the 8th, we will have our final data manager training webinar, which will be on reporting. So hope to see you guys tomorrow and next week.